Good morning, everyone. I have perhaps one of the best honors that I could possibly have in introducing Serena Hugh as the honored orthopedic guest. Much like if I had Michael Jordan up here, I think this may be the fourth or fifth time that I've had the pleasure of introducing Serena in different organizations across the world. And I'm going to tell you that she is at the absolute pinnacle of our specialty of spine surgery. She was educated at Cornell. She did her medical training at McGill, did her residency at Hospital of Special Surgery, and then did a fellowship in spinal deformity surgery at Rancho Los Amigos Medical Center. She has served numerous roles within her institution, including currently being professor and vice chair for the Department of Orthopedic Surgery. She served as the chief of spine surgery at Stanford University. She has served numerous roles within the Scoliosis Research Society, culminating in being the president. She has been the president of the American Orthopaedic Association. That's similar to being, for the neurosurgeons, being the president of the Senior Society in neurosurgery. And in all of these roles, she has served with absolute total distinction. She is an accomplished academician. At the last time that I had looked, she has 338 peer-reviewed publications, and some of these publications are absolutely transformative to our specialty and range from how to improve patient outcomes and patient experience through how to do different surgeries in much better ways to instructional areas that have taught us so much in fields of things like high-grade spondylolisthesis and scoliosis. She is a dedicated humanitarian and has traveled throughout the world to give her skills and knowledge to people that really have benefited from the most. She has had these roles as a leader, mentor, educator, scholar. She's a world-renowned surgeon. She's a good skier and an absolute fabulous friend. So I am so proud and pleased to introduce Serena and give her the Joint, Spine, and Peripheral Nerve Section Award for the Honored Orthopedic Guest. Serena. Oh, it's not one more thing. Let's hear it. Whatever I mean.
So thank you so much for that very nice and generous introduction, Chris. The reason he keeps introducing me is because I keep following in his footsteps, because I want to be like Chris. But I'm working on it anyway. So in selecting a title for this talk, it was actually, I thought I wanted to talk about the art of spine surgery. And ironically, two of the other speakers talked a lot about that. So I'm pleased that we are spending more attention talking about this than sometimes we do. So these are my disclosures. And so I want to point out that the science of what we do has really come a long way. And I think we all know that, and this meeting spends a lot of time focusing on that. This x-ray is a picture of a early spine fusion where they placed a tibial strut at what was then called the Society for the Ruptured and Crippled. And they learned that from a tree farmer who did grafts for his trees. We've come a long way. Now we do motion preserving treatments for growing patients, and we have much better instrumentation for adults as well. Some of the great advancements we've had that have allowed us to improve our safety include, when I was started, we did wake-up tests. Now we have SSAPs, MMAPs, and even dynamic spinal cord monitoring, and increase neurologic safety in these high-risk patients. I used to put in screws with fluoroanatomic landmarks, and now we can navigate. We can use augmented reality and even robots to make sure we have accurate placement of our instrumentation. And we continue to improve our radiographic targets to try to better understand where our patient's spines should be in space. This is a moving target, but we're still working on it. But again, it's much better than when I first started. And then we have rods to help us get there for those targets that we have decided are better for our patients. When I started, we would send patients off for their pre-op clearance, and I'm sure that most of the internists that we sent them to had no idea the magnitude of the physiologic load that we would put on our patients to get through these spine surgeries. And now we have, based on data and science, better areas of optimization for our patients. So we have tools to become the best surgeon we can be, and you can actually buy this set on eBay if you want to become an endoscopic surgeon. And these tools allow us all to achieve excellent surgical outcomes, not just people who happen to be Chris Shaffrey or Larry Lenke. But what do patients look for? So I thought I'd ask AI, which I generally don't use a lot, but they do call from what's out there. And as expected, a lot of this is released on our training, our experience. But third on this list is communication and trust. And this reflects some of the prior talks that I think were nicely put together. And when you look online, what patients see and what patients look for are that communication and trust. And this is not just about our training, not just about our outcomes, but again, how we communicate. I heard a recent comment from a random medical student who decided not to go into surgery because she said, surgery is all done by robots. And I think we need to be careful not to allow society to label us as robots or to label us as just technicians. So I just have a couple of cases that I thought would illustrate the kind of the art of medicine and reflect a little bit more on what some of the prior talks have shown. So this patient, he's only 43 at this time, and he had back pain for many years, but worsening deformity for about 3 years. You can see he has a complex history related to his Crohn's disease as surgery related. And importantly, among his past medical history includes a history of meth use, which was remote, and also a history of heroin use, which was as recent as 6 months ago. Although he quit smoking, he still uses THC regularly. He's embarrassed by his appearance, and he's the primary caregiver for his mother who had a stroke. So, how many people in this room would offer this patient surgery? Okay, yeah, and then how many would not? Okay, yeah, I mean, this guy has a lot of flags. So he's got a couple of things going for him. He hasn't taken an illicit drug for 6 whole months. He doesn't take opioids now. That's probably a good sign. And his mother did come to him with this appointment, and he says his brother from Arizona would fly in for postoperative support. But look at all these cons. He has a questionable support system. He has illicit drugs in the recent history. We don't really know why he has this progressive deformity, and he has severe intra-abdominal scarring and is on medication that can interfere with his healing. And later on, I learned that he had an abusive father who sent him off to a school where they're now investigating for whether or not they abused the kids there. And the mother is very worried that if her son has the surgery, who's going to take care of her? I found these CT scan from when he had his abdominal surgery, not very exciting. You know, many years later, again, not a lot that's impressive from the standpoint of why he'd have this horrible deformity. And again, a CT scan which shows some bone borderline osteopenia. So I'm not sure whether this was the best judgment, but we worked on getting a negative drug test, getting his DEXA scan, and tried to optimize him a little bit better. So we had him doing supine stretching. You could actually bounce a quarter off his stomach because it was so tight, and daily walking for about 30 minutes a day. And he returned in 6 weeks. He was compliant based on the people who accompanied him, but his deformity continued to get worse. So what would be the surgical plan? Do we go all posterior to with multi-level laterals or T-lifts? Do we do a PSO? And then, of course, the question of how proximal. So we did a staged procedure because I was concerned about how much scarring he would have. And I think a lot of people in the audience who said they would probably not operate on this person are wondering where this story is going. Sure enough, we did the 3-level laterals and 2-level anterior. The day between his stages, he cried and cried. He refused to have a second stage. He said he couldn't bear the pain. And we had to basically decide whether or not to stop there or go ahead. Thankfully, he had neighbor Nellie, who's the one that I got a lot of this other history from. And neighbor Nellie knew the patient like a son. And between the two of us, we convinced him that having gone this far, if he wanted to stand upright, he really needed to kind of, I guess, buck up and proceed. So he completed the surgery. These are his intraoperative films. And not surprising to anybody who has operated on a patient with a prior drug history. He, after his first stage, was crying constantly. He told me he wanted to die. Please put me out of his misery. And I would hold his hand and say, I'm so sorry. I promise it will get better. On a second day, I can't bear the pain. Psych was telling me that he wanted to hit his head against the wall. And all I could say was, I wish I could make it better faster. On a third day, he didn't think it would be this painful. And all I could say was to, again, hold his hand and promise he wouldn't regret it. But on that day, we managed to get him up, and he realized he could stand up straight. And there's nothing like a patient's face like lighting up when he suddenly realizes he can look ahead and stand like a normal human being. So he's now 2 months post-op, and he's weaning off his narcotics. He walks regularly, and he's actually considering returning to work. And every time we see him, he hugs and thanks everybody on the team. And he's been in a few times just because of the pain management issues. Another case of a 77-year-old VA patient who's had the flat back deformity that created here after his multiple surgeries. And important in his history is the fact that he had a fall with an intracranial bleed and had some memory loss. He's got a fairly benign past medical history, and importantly, he has a wife that he's been married to for 52 years. He's failed conservative therapy. He's got this lumbar MRI that shows adjacent segment disease and a solid fusion with his prior fusion levels. And so we talked about a surgical plan, and we can argue about this, whether to do a PSO, how high to go, interbody cages, and all that kind of stuff. But in the pre-op preparation, they wanted to do an echo, and the patient was surprised because he'd never had a cardiac history before. His wife wanted him to have the surgery because she wanted him to walk more. She knew that was good for him. That would help him longevity-wise, health-wise. But she wanted to know how likely is this going to be for him to be able to walk better. And so certainly we all in this room who operate on flat backs in patients who are 70 and plus, we could tell her that he will walk better and more, and this will make him better. And he needs this because of his spinal stenosis. But I think we also have to explain to her that he will have a lot of pain for anywhere from several weeks to several months, and she will need to push him more. And so that was kind of an interesting and important piece of data for her. So he actually, she canceled his surgery, and he's actually not even had his cardiac workup. So we'll see what goes on from the standpoint. But she decided that was not something that she thought would be good for him in the long run. So we need to think about when to encourage or push the patient. We need to listen to the patient and their actual goals and think about cultural differences. So I think we're very, very good at focusing on the science of our surgical goals, on the improved function, on creating a stable and balanced spine, and decreasing the risk of subsequent surgery. But like some of the speakers before me, I think we also need to remember the art of spine care, to understand the patient's goals and expectations, guide them to appropriate choices for them, and support them through that long preparation and recovery. So I thank you very much for your attention. I thank Dr. Sisson for inviting me and including me, and appreciate all your attention.